Thank you, Dr. Sanjay, for elaborate introduction. And I'm extremely grateful to your august meeting for this opportunity. Greeting from Sir Ganga Ram Hospital. The topic which has been allotted to me by Dr. Sanjay is the pathogenesis of the hepatic steatosis, insights into the potential treatment options. Now, all of us know that fatty liver disease by default is the hepatic manifestation of the metabolic syndrome. There is something wrong with the metabolism by which the patient comes to you carrying a report of an ultrasonography showing that he has a fatty liver. Community prevalence in India, as per the data published repeatedly by Dr. Ajay Duseja, Dr. S.P. Singh and others have shown that we have a baseline prevalence of about 5 to 28%. And it affects almost all ages with increasing prevalence, not only in the childhood, but also in the women recently. The reason why Dr. Sanjay has chosen this topic is that because the prevalence is far more than the common diseases which we see on day-to-day basis in the form of hepatitis B, hepatitis C, and if you see the prevalence, it is far more, and that is precisely the reason why we are talking on this weekend of pathogenesis of fatty liver disease. What is fatty liver disease? By default, it is defined as an ectopic accumulation of the fat which occurs in more than 5% of the hepatocytes. Any fat which is less than 5% of the hepatocytes is physiological and not pathological. And then after that, it presents with a wide variety of symptoms and wide spectrum of the disease process, which can vary anywhere from healthy liver, just showing an ultrasonography features of fatty liver, to development of the steatotic liver, to development of inflammation in the liver, which we now call MAFLD or MASH, and subsequently developing cirrhosis and its end-stage complication of decompensation as well as hepatocellular carcinoma. Why is it that we develop fatty liver disease? In fact, there are multiple theories which have been propounded over a period of time. As long back as in 1998, Day and James had proposed a theory that it is a two-hit hypothesis. That means you have a naive virgin liver on which you have accumulation of the fat, and it is waiting for the second hit to get into a diseased liver called NASH or development of the cirrhosis of the liver. There is another theory which was propounded by Dr. Herbert and Alexander in 2012. According to that, these are two parallel etiologies and two parallel reasons for development of the fat in the liver. In one particular instance, you just have a simple deposition of the fat, and from fat, you can develop cirrhosis of the liver because of the genetic problems, rather than going through a process of first steatosis, then inflammation, and then the development of the cirrhosis. These are different entities. And now possibly, if you combine the two, there is a new concept that patient possibly has multiple hits. The first hit is that you are having a disease process of development of fatty liver disease, followed by development of inflammation, which ultimately leads to onset of cirrhosis and the hepatocellular carcinoma. So what are the drivers of various clinical phenotypes we have? We have drivers of the fat, which are in the form of diabesity, high caloric intake, in development of insulin resistance, and particular genes which predispose to development of fat in the liver. Then you have drivers of NASH. That means the fatty liver gets converted into an inflammatory disease process called NASH, which is now recently been referred to as a MASH or MASLD. The drivers for development of inflammation could be either cellular, metabolic, or development of the reactive oxygen species, especially in selected individuals who have a propensity to develop this inflammation. Finally, all this leads to development of fibrosis of the liver, which manifests in the form of decompensated cirrhosis and development of hepatocellular carcinoma. And these drivers of the fibrosis are in the form of hepatic stellate cells, Cooper cells, chemokines, and the genetics. Before understanding anything about the fatty liver and the incoming processes which then try to flow from there onward, I think it is important to understand what is insulin, what does it do in the body. Insulin basically binds to its receptor, which leads to dimerization. Now, this dimerization of the beta subunit, which is the intraplasmic part of the insulin receptor, leads to phosphorylation of the various downstream signaling pathways in the form of iris 1 and 2, which subsequently leads to activation of the PIK3 and AKT. This leads to stimulation of the lipogenic gene through this, and by stimulation of the nucleus DNA fragment, which tries to have increased production of the lipogenic genes through the stimulation of SRAP1C. That leads to even suppression of the gluconeogenesis, finally leading to activation of the AKT, which is important in the metabolism of number of processes, which I will come to. And this is one of the mechanisms by which various therapeutic agents have been shown to affect one of the suppression of these metabolic pathways. In the normal course of the events, if you give an insulin to a normal individual, then via AKT stimulation, it leads to translocation of the insulin receptor onto the cell membrane, which increases the glucose uptake into the cell. By stimulation of the BCL2 mechanism, it causes inhibition of the apoptosis. By inhibiting CRAP, it inhibits gluconeogenesis. And by promoting TORC1, it promotes synthesis. So these are the normal basic mechanisms by which the insulin acts in a given individual, and it also promotes the lipogenesis by stimulating this enzyme. So this is the normal mechanism of insulin. So this is what happens. It is just a diagrammatic diagram to show that this is an insulin receptor in which the insulin gets attached, the beta units gets stimulated. There is a phosphorylation of iris-1, which leads to activation of the number of pathways downstream, which leads to activation of all the physiological processes in a normal individual after the intake or the use of the insulin. So this is what insulin does in a normal individual. It promotes de novo lipogenesis. That means once you have eaten, insulin is released. It will try to promote the deposition of the fat in the liver. At the same time, it inhibits fatty acid oxidation. That is understandable. If you have a lot of stores of the glucose in the body, because of which the insulin got released, so it will by default inhibit oxidation. At the same time, it also inhibits gluconeogenesis and promotes glycolysis. So what happens in patients who have insulin resistance? So the lipogenesis inhibited fatty oxidation is promoted. So that means the fatty acid which were supposed to be suppressed by insulin, they get suppressed because of the development of insulin resistance, and the gluconeogenesis inhibition, which was caused by the normal insulin, gets lost. So what it results in an insulin resistant state, which leads to hyperinsulinemia, which leads to delipogenesis, and there is an exacerbation of the insulin resistance. Let's see, how does fatty liver develop in a given individual? In fact, there are multiple factors which are contributing to it. You have excessive consumption of the calories in the form of diet or the fructose. You have an intricate metabolism of the fat which enters into the cell. You have altered microbiome in the gut, which is likely to convert a fatty liver to a non-fatty liver disease state. You have genetic factors which predispose you to development of the fatty liver. And there are processes which are related to development of insulin resistance, which will cause all the havoc, which I'm going to show you. So let's start with the effect of the dietary fat and the fructose, which we tend to consume. Now look at an individual who is consuming a high caloric diet. Possibly is also consuming a lot of high saturated fatty acids coupled with high carbohydrate diet and a lot of syrups containing a lot of fructose. So this gentleman is likely to come down with high adipose tissue mass. So this is the typical obese person. In fact, majority of the patients who have non-alcoholic fatty liver disease are obese. So if you have a lot of calories, if you have only consumed glucose, there is only one way of storing glucose, that is glycogen. If you look in the liver only, you cannot store more than 500 grams of glucose, whereas in the muscle you can store few kg of glucose in the form of glycogen. So given the choice, if you have to survive only on glucose as a storage product, you will not be able to live beyond 6 to 18 hours, because there are organs in the body, including RBCs and the brain, who regularly require glucose for the day-to-day activity and the day-to-day functioning. But if you have taken in a lot of carbohydrates and proteins, there is a concept of de novo lipogenesis. That means this excessive carbohydrates which you have consumed can be stored in the form of fatty acids and triglycerides. This is a very important thing to understand, because glucose cannot be stored. If it has to be stored, it has to be stored in the form of lipids. Now, what is the de novo lipogenesis? It's basically a process in which the incoming glucose goes into the pyruvate. Pyruvate enters the Krebs cycle. From the Krebs cycle, you have citrate, which gets released as a 6-carbon moiety, and then it is again converted back into the acetyl-CoA into the cytoplasm, and this acetyl-CoA is used as a substrate for production of the fatty acids within the cytoplasm. There have been ways of trying to suppress this so-called gluconeogenesis. That means excessive food which you are taking, excessive glucose which you are taking, gets stored in the form of free fatty acid by this process of gluconeogenesis. There are ways of suppressing this, but somehow in clinical trials, they have not been found to be useful. So what do these basic mechanisms do? You have insulin, which is acting through AKT pathway. It is acting through the TOG pathway, leading to the exacerbation and activation of the SRAP gene. This SRAP gene tries to stimulate a large number of the lipogenic genes, which will try to increase the production of fatty acids from all the sources which are. The sources of the fatty acid, which I'll be coming to you soon, can be in the form of fatty acids coming from the diet, or the fatty acids which are generated by the excessive availability of the glucose. So all that gets deposited into the tissue. Earlier it was thought, so what if you have fat? You look obese and you look ugly. And everybody thought that deposition of the fat in the liver was just an inert energy source. But nowadays we realize that fat is not a simple dump energy source. It is an active moiety. It is a smart guy which is involved in total energy metabolism. It is involved in insulin sensitivity, as well as has effect on the appetite, immunity, and immunity reproduction. So a large number of the drugs are trying to act at this level to take care of the fatty liver disease. And the classical example is one of the drugs called GLP analog or semaglutide, which has the maximum sales for any drug in the pharmaceutical industry as of today. So let's see what happens once you have a lot of fat which is coming into the adipose tissue. How does the adipose tissue handle a lot of fat? Now, with passage of time, if you have too much of the fat, there is a concept called adiposopathy. That means positive calorie balance and sedentary lifestyle leads to deposition of the fat in the liver. With energy surplus, gradually and slowly, this fat tends to get hypertrophied, and hypertrophied fat, because it becomes sick, then it tries to spill a lot of non-esterified fatty acids into the blood, leading to the metabolic syndrome. And that is the reason once you have insulin resistance, which is related to diabetes, obesity, has also association with the other metabolic disorders, including cardiovascular disease. So let's see what happens to the fat which has been coming to the fatty tissue in a person who was not otherwise obese. It can lead to adipocyte hypertrophy. You have an adipose tissue which keeps on getting a lot of fat. The fatty tissue is getting hypertrophic, and this hypertrophic tissue at some point of time has effect on its blood supply, leading to the hypoxia, and that stimulates the occurrence of inflammatory cascade, which leads to further problem downstream. So you have adipocytes, which, because they are increasing in size, there is a cytoskeleton disassembly. As the size of the hepatocyte is increasing, the membrane becomes unstable. You have impaired insulin signaling that leads to insulin resistance. Insulin resistance leads to lipoprotein lipase upregulation. There is also upregulation of the beta adrenergic receptors. So you have increased leptin, you have increased insulin and impaired insulin signaling and insulin resistance, all leads to increased lipolysis, because as I've already mentioned, that insulin purpose is to stop lipolysis of the fatty liver disease. And once you have insulin resistance, you have more and more fats which will keep coming into the systemic circulation. At the same time, adipose tissue, once it is getting hypertrophied, there is a deposition of the cholesterol onto the membrane of the adipocytes. So that leads to decreased uptake of the fatty acids from the circulation into the adipose tissue. So even though fatty tissue looks the tissue which is taking a lot of fat, but it is a diseased tissue. So the disease uptake of the fat from the circulation again leads to a lot of availability of fat in the circulation. So adipocyte gets hypoxic because of the failure of the angiogenesis to keep up the pace with the adipocyte mass expansion. There is a compression of the surrounding vessels, as well as there is a depletion of the vasodilatory nitric oxide, which is consumed because of the oxidative stress which is occurring within this hypoxic adipocyte. So what all this is leading to change in the phenotype of adipocyte. So you have development of large number of the reactive oxygen species from the mitochondria. That leads to oxidative stress. Oxidative stress leads to changeover of the macrophage from the useful anti-inflammatory and friendly M2 type of macrophage to a diseased macrophage called M1 type of macrophage, which releases pro-inflammatory stimuli. So the mere presence of the fatty tissue in the adipose cells leads to adipose hypertrophy. That leads to impaired signaling because of the disassembly of the cytoskeleton. That leads to oxidative stress. Oxidative stress leads to change in the type of macrophages which are present from the M2 to M1. At the same time, this so-called friendly adipokine called adiponectin, which is so important in increasing the insulin utility, in increasing the uptake of the glucose into the cell, tends to get decreased. At the same time, you have leptin, which is supposed to be decreasing the appetite at the hypothalamic level. It is a anti-fibrotic agent. It tends to increase because of the occurrence of the insulin resistance. So you have an imbalance between the normally occurring adipokine and leptin level. Adipokine level keeps on decreasing and the leptin level keeps on decreasing. So what is the end result of all this insulin resistance development on glucose and lipids in the periphery before the fatty acids and from the diseased adipose tissues reach the liver? On the adipose tissue, there is an ongoing lipolysis because the insulin, which was supposed to stop lipolysis at the level of the fat, is getting resistant. At the skeletal muscle, you have insulin resistance so that the glucose cannot enter the muscle cells, and hence the persistent hyperglycemia. And at the level of the liver, you have ongoing gluconeogenesis, ongoing de novo lipogenesis, and there is a suppression of the gluconeogenesis. All that is lost. That is where this new concept of utility of GLP-1 agonists come, which I'll explain you how these drugs are useful in patients with fatty liver disease. So there are, in fact, other effects of the insulin resistance on adipose tissue. It leads to there is a suppression of the adiponectin production. So there is a decreased insulin sensitivity. Its anti-inflammatory, anti-fibrotic function is gone, and you have more release of inflammatory cytokines, which tend to cause pro-inflammatory and pro-atherogenic state. This is the area where SGLT2 inhibitors are supposed to be acting, and that's the reason they are useful in patients with the metabolic syndrome. So what ultimately, ladies and gentlemen, is happening is that after a lot of fat has entered the adipose tissue of this gentleman, you have a phenotype in which there is less adiponectin, which was friendly. You have an enemy adipokine leptin, which has gone up. You have changeover from M2 to M1 pro-inflammatory macrophage, which release a large number of the pro-inflammatory cytokines like IL-6, monocyte chemoattracting factor 1, as well as TNF-alpha. This ultimately leads to a stage where there is, because of the expanding adipocyte, there is also remodeling of the adipose tissue. That means adipose tissue is trying to expand when it does not have a space to expand. That is the reason there is a area of surrounding the area of the adipose tissue in the vicinity in which there is a release of the pro-inflammatory cytokines. So what is being released by a sick adipose tissue is a bus which is full of cytokines, which is full of insulin, which is full of glucose and pro-inflammatory and pro-fibrogenic substances, which ultimately come to the liver. So this is ultimately what is happening in the adipose tissue. adipocytes which were gradually and slowly expanding. As they are expanding, they are going to break up the membrane of the adipocyte. Disruption of this membrane of the adipocyte leads to the impaired insulin signaling. Once there is an impairment of the insulin signaling, you have upregulation of the lipolysis. There is an increase in the leptin. Unchecked lipolysis leads to release of a lot of non-esterified fatty acid into the circulation. And because there is a lot of depletion of the cholesterol from the membrane, so the adipose sick tissue now cannot pick up the fatty acid from the tissue. So this all leads to the ability of the adipocytes to tolerate whatever has been happening till now. So in fact, because of the hypoxia, because of the oxidative stress, because of the inflammatory changes, large number of the adipocyte death. In fact, this is an intuitive concept. Most of us think that in fatty liver disease or in patient with fat, adipocyte tissue is hypertrophied. The fact is that because of the hypertrophy, there is a substantial death, and there is study to show that 30% of these adipocytes die. And once they die, they will have further release of inflammatory cytokines. So inflamed sick adipose tissue is coming into the circulation because of the adipocyte hypertrophy, insulin resistance, oxidative stress, releasing a large number of the free fatty acids, leptin and adiponectin, leading to a multitude of the problems which not only affect the liver, but also the other important organ like kidney, heart, etc. So this is what is happening at the liver. A person who had consumed high calories, has been taking high fructose, high protein diet, has a diabetes, and now you have excessive fat, which leads to release of increased fatty acids in the peripheral tissue. And because of the development of the fatty acid tissue, fatty acids cannot be picked up at the level of the adipose tissue. And because of insulin resistance, there is a persistent lipolysis. If you are consuming at the same time high fructose diet, that has a unique problem of absorption through the GLUT4 in the intestine. And from there, this fructose enters through the GLUT4 into the hepatocytes, and bypassing the cycle of glycolysis, it serves as a substrate for development of fatty liver disease because of the gluconeogenesis. So let's see what happens once the fatty acids tend to enter the liver. So what fatty acid, the inflamed adipose tissue is going to give into the circulation, and from the circulation into the liver is a hyperinsulinemia. That means a lot of insulin is coming into the liver, and because of the diabetes, you have a lot of glucose which is coming into the liver. Now, the glucose which comes into the liver can be stored as a glycogen, or it can be converted into glycerol, which can again be used for the formation of the fatty acid liver, free fatty acid, which can get converted into triglycerides. Insulin, which comes into the liver, leads to persistent release of free fatty acids into the circulation. So of all the free fatty acids into the circulation, 60% come from the free fatty acid into the circulation, 25% come from the GI tract, whereas 15% come from the other sources. So once the glucose has entered into the liver because of the hyperglycemia caused by the insulin resistance, it can go into the Krebs cycle, and from there it can, through the production of acetyl-CoA, it can be used for the production of the free fatty acid and hence triglycerides. So incoming glucose can also be used to produce and stimulate SREP, which increases the synthesis of the lipogenic gene. And this increasing glucose concentration can also be diverted to produce a lot of fat by the process of gluconeogenesis. So you have so much of the fatty acid tissue which is coming into the liver. Let's see how the liver handles this tissue. So this is the so-called first hit. Look at the beautiful normal liver, which looks pristine, clear on histopathology and in normal ultrasound of the liver. Fatty liver is basically deposition of the fat in the liver. This is what is happening as the first hit of the liver because the fat, too much of the fat is coming into the liver. Of these, as I have already said, 60% comes from the adipose tissue, which are persistently releasing free fatty acids. 15% comes from the dietary sources like overconsumption of the fat or the fructose and other substances which I have mentioned. And 25% of the incoming fat to the liver comes through the de novo lipogenesis, which primarily occurs through the non-fatty acid sources. So what is the fate of the fatty acid which tends to come into the liver? So too much of the free fatty acid ultimately gets attached to a moiety called glycerol. Now, glycerol is something which is produced from the glycolysis cycle through a alternative pathway. So three fatty acids get attached to this a core or skeletal structure called, and it forms something called triglycerides. These triglycerides can either be stored in the form of lipid droplets, or they can be hydrolyzed for purposes of different manufacturing of the different hormones and other structures, or they can be exported out in the form of VLDL particle. In the healthy state, if you look at only 5% of the total lipids tend to occur because of the de novo lipogenesis. Whereas in patients who have fatty liver disease or MESELD, there is a 3 times higher activation of the de novo lipogenesis, which is a problem which may be related to the genetic effect. In fact, there is an upregulation of the lipogenic genes. That means whatever you eat, whether it is fat or whether it is carbohydrates, you are likely to have more deposition of the fat in the liver. Moreover, there is a dynamic relationship between the deposition of the fat and development of the insulin resistance. Liver steatosis can induce insulin resistance. I'll explain you how. But insulin resistance does not always need to be accompanied by hepatic steatosis. This is important to remember. Insulin resistant development might depend on the type of the fat accumulated. Not all fat which is accumulated in the liver is toxic. In fact, TAG by default or triacylglycerol is a friendly lipid. There are other lipids like diacylglycerol or ceramides or saturated fatty acids, which are more potent inducers of insulin resistance than triglycerides. So there is a two-way communication between insulin resistance and deposition of the fat, and deposition of the fat and development of the insulin resistance. Let's see how does this insulin resistance within the liver or development or deposition of the fat in the liver further aggravates insulin resistance. Now, depending upon the type of the fat which you have in the body, either you can have a fatty, either you can have a fat in the body which is saturated, or the fat in the body which is not saturated. Now, if you have a fat which comes in the liver in the form of monosaturated fat, and if it gets converted into triacylglycerol, then it forms a lipid droplet. Now, the deposition of the fat in the liver leading to the formation of the fatty liver, in fact, is a protective mechanism of the part of the body. What happens is, if this total machinery is exhausted and it is overwhelmed, that is the time when other types of lipid, other than triacylglycerol, other than TAG, that is something which is going to give you more problems. So what are these other bad fats? These are saturated fatty acids as well as free cholesterol and ceramides. These are the toxic fatty acids which are going to give you the trouble. In fact, PPAR agonist of different varieties, and there have been various types of PPARs which are available for taking care of the metabolic processes which involve the fatty acid and the glucose metabolism. They have been used to take care of the insulin resistance and increase the fatty acid oxidation in various steps of the pathogenesis of fatty liver disease. We have various types of PPAR agonists. You have saroglitazar, which is available and approved by Indian authorities for use in patients with fatty liver disease. It acts on alpha and gamma PPARs. You have pioglitazone, which is the time-tested drug for treatment of diabetes and NAFLD. It acts on PPAR gamma. You have other elafibranor, which acts on alpha and delta, and you have a pan-PPAR agonist called linafibranor. These are the PPAR agonists which acts on different areas of metabolism of the fat in the liver, producing changes which are important for increasing the insulin sensitivity and trying to increase the oxidation of the fatty acid within the liver. Now, you have a fat which is in the liver. So far as it is a TAG, it is supposed to be good, but it is looking for either a second hit, which can be in the form of a bad liver, or a second hit, which can be in the form of inflammation, to change over from a bland fatty liver, which has a totally normal lifespan without any adverse effect on the longevity of the individual, to a NASH in which 20% of the patient may have fatty cirrhosis of the liver, and those with cirrhosis will have decomposition in HCC. So this simple bland tag containing fatty liver is looking forward to have a second hit. That second hit could be in the form of intrinsic different type of fat or different type of components of inflammation or stress, which I am going to explain to you. So how is it that a simple fat which is present in the body cannot be a normal fat? Because by just simple examination of the fat, you cannot make out whether this fat is made up of a tag or made up of diacylglycerol, free cholesterol, cholesterol esters, ceramides, and phospholipids. Mind you, not all fat in the liver is friendly. Now, how will one decide that the incoming fat will get stored as a tag or it will get converted into the so-called noxious or the derogatory or harmful fat? Now, by default, all fatty acids should primarily be converted into tags and it should be stored. But the liver has a limited mechanism to store it, and there is a compensatory mechanism so that it will try to buffer against any injury caused by the liver. Whatever is stored, part of it can also be exported. So severity will depend on how much the liver is able to store in the form of tag. So far as tag is stored, you are not likely to have any injury. Problem occurs when you can't take a lot of saturated fatty acids. Now, saturated fatty acids cannot be converted into a tag unless it is desaturated. This desaturation occurs by this enzyme called SECD1. So if you have a mutation of this enzyme, you will have less fatty liver, but more saturated fatty acids. So if you do an ultrasound, liver will show less fat, but because you have more unsaturated fats, so this is giving more likely to give you trouble because this is going to be a noxious fatty acid. Similarly, you can have a methionine or choline deficient diet, which significantly suppresses SCD1. So you have more saturated fatty acids, which can induce apoptosis. At the same time, saturated fatty acids tend to increase reactive oxygen species and they tend to generate toxic metabolites. Another form of fatty acid, which is noxious for the hepatocytes, is when the fatty acids cannot be converted into tag because the machinery is already overwhelmed, so it gets attached to this substance called sphingosine. So this leads to formation of a compound called ceramide. Now this ceramide is something which leads to increased permeability of the mitochondrial membrane. It will initiate apoptosis, and then this leads to more insulin resistance and more inflammation within the liver. This is the area where resmetirom, which has been released as a first drug for treatment of non-alcoholic fatty liver disease, is supposed to be acting. So increased fatty acids can be in the form of either bland fatty acids in the form of tag, or once they get converted into noxious fatty acids in the form of saturated fatty acids, they can lead to production of a chain of events which can initiate inflammatory processes. Similarly, there may be a development if fatty acids are not getting converted into tags, then they can convert it into LPC, that is lysophosphatidylcholine, and this is supposed to cause lowering of the cardiolipin levels that leads to transmigration of the cytochrome from the mitochondria and leading to apoptosis. So you have, in addition, a formation of a substance called diacylglycerol. So monosaturated acid fat gets converted into diacylglycerol and from there into triacylglycerol. So if there is an impediment of conversion from monosaturated fatty acids to tags, there may be development of intermediary substance called diacylglycerol. And this has been shown to be one of the potent inducers of insulin resistance as well as inflammation. So this is the fat which is getting deposited into the liver, and then this fat in the liver in the form of tag is causing insulin resistance. So this abnormal, noxious and toxic fat called DAG is responsible for development of insulin resistance. Now, there is also a cholesterol which is not getting utilized because of the development of the fatty liver disease, and high cholesterol in the membranes, in the plasma membrane of the hepatocytes and the adipose tissue lead to the dysfunction of the membrane, lead to leaky membranes, and the excessive accumulation of the cholesterol in the Cooper cells also makes them pro-fibrogenic. This is again where resmetirom is supposed to be acting. That is the reason in patients who have a high cholesterol, it is conventional to give them statins because the higher the cholesterol, more will be the hepatic steatosis, more will be the insulin resistant. In addition, high cholesterol also have a detrimental effect on the endoplasmic reticulum, on the mitochondria, as well as it also tends to increase the endoplasmic reticulum stress and leads to excessive apoptosis. Now, once you have the hepatocytic stores which are full of fat, what does the body do? The best is to get rid of the fat. That means you try to oxidize the fat. All this fatty acid oxidation occurs in the mitochondria. But problem we should understand that the mitochondria also has a limit to metabolize or oxidize this fat. So there is a limit, and hence with passage of time, the mitochondria tends to get exhausted and it leads to development of the mitochondrial stress or the endoplasmic reticulum stress. So mitochondria, which is taking in the fatty acids for beta oxidation, by default is likely to have some 5% of the normal beta oxidation will remain incomplete. This incomplete beta oxidation during a process of continuous fatty acid oxidation leads to generation of a lot of reactive oxygen species. In the normal course of the events, these normal reactive oxygen species can be taken care of anti-inflammatory antioxidants, which can take care of in diseased liver. But in a patient who has a persistent insulin resistance, the insulin resistance is the biggest boss which is giving all the instruction. There is a excessive fatty acid production. It also inhibits the malonyl-CoA. So that means it prevents the entry of the fatty acid into the mitochondria. So insulin resistance is also prevented fatty acid oxidation into the mitochondria. And since now the fatty acids cannot be oxidized into the mitochondria, they tend to go into the cytochrome and peroxisomes. And mind you, the entry and the oxidation of the fatty acids in the peroxisome and cytochrome is more detrimental because they are more likely to produce a lot of these so-called free radicals in the form of superoxide ions, hydroxyl ions, etc. And these antioxidant defenses, they tend to get depleted. So you have a lot of fatty acid which is fatiguing the mitochondria, and malonyl-CoA is also directing the fatty acids to be oxidized in the peroxisome as well as the cytochrome, which lead to overproduction of this reactive oxygen species. What this leads to a large number of the free radicals which cannot be consumed by the antioxidants. So they can combine and damage the DNA. They can combine with the protein to cause proteolysis, and they can get bound to the lipid, leading to the production of the lipid peroxidation as well as the oxidation of the lipids. So this is another region where resmetirom is supposed to be acting. So a lot of free radicals are generated because of the exhaustion of the mitochondria as well as the occurrence of fatty acid oxidation in the cytochrome and the peroxisome. So what is this leading to? So you have a lot of free radicals which get converted into different type of dienes because of the combination either with lipids or the proteins, and they can be stopped by a combination of the antioxidants, which could be enzymatic and non-enzymatic. But once that particular capacity of the antioxidants to take care of this pro-inflammatory reactive oxygen species, then one is likely to have injury to the hepatocytes and the organelle. And this is how the injury occurs. You have a saturated fatty acid attack. You have free radicals which go and attach to the hydrogen moiety of the lipid membrane, which leads to deconjugation of this particular moiety, leading to the formation of the peroxide radicals. And these peroxide radicals go and attach to another part of the same membrane, leading to the chain reaction, which will only stop once you give antioxidant. That is where the role of vitamin E, which was propounded for the first time by Dr. Professor Arun Sanyal's group as a treatment of non-alcoholic steatohepatitis. In addition, the fatty acids which are toxic in the liver, they not only cause endoplasmic reticulum stress, they also tend to cause insulin resistance and promote inflammation. At the same time, if you have a lot of fatty acid which is coming into the mitochondria, by default, there is an upregulation of this enzyme called uncoupling protein 2 enzyme. So which leads to wastage of the hydrogen or the proton pump, which is used for production of the energy. So what is happening is, because of the upregulation of the UCP, there is not much energy which is being produced in the hepatocytes as a part of the oxidation of the beta fatty acids and the beta oxidation change in the mitochondria. So fatty acid oxidation coupled with cholesterol will lead to the endoplasmic reticulum stress. That will lead to occurrence of and the stimulation of this protein called unfolded protein. What this means is that you have a mitochondria which is getting exhausted because it needs to produce a lot of ATP. At the same time, you have upregulation of the UCP, which is wasting the production of the ATP because it is uncoupling the hydrogen from the electron transport chain. And with passage of the time, the mitochondria get fatigued. So this is a fatigued mitochondria which gets exhausted with passage of time. So increased free radical production, antioxidants are initially upregulated to take care of that, but eventually because of the ongoing continuation of the inflow of the fatty acid into the mitochondria, the stores of the antioxidants are decreased, leading to oxidant stress. This oxidant stress can also occur in the endoplasmic reticulum. Endoplasmic reticulum is a protein which is important for so many functions to occur in a day-to-day functioning. It can lead to formation of post-translation modification of the protein. It is important for the calcium storage. This is the area where lipids are forming. This is the area where cellular membrane biogenesis is occurring. And this is the area where most of the protein and the drug metabolism is occurring. So the moment you have stress onto the endoplasmic reticulum, it is likely to produce apoptosis and it is likely to produce inflammation. So what happens in patient with the insulin resistance? You have increased apoptosis, you have increased lipogenesis. That leads to altered VLDL synthesis. Now, because ER stress is there, so this incoming tags cannot be converted into VLDL because they have to be formed onto the endoplasmic reticulum. So there is an accumulation of a lot of fat within the liver that leads to stimulation of the JNK pathway. And this disease endoplasmic reticulum having UPR is likely to be prone to get apoptotic pathway. So increased fatty acid influx into the liver is resulting in increased fatty acid into the mitochondria. And as the mitochondria are getting exhausted because of the excessive use, it leads to suppression of the respiratory chains because electron transport chain is diverted because of the upregulation of the uncoupling protein. So there is no increase in the respiratory chain in MASH because of the UCP regulation. And finally, with passage of the time, the mitochondria tend to become dysfunctional. As the mitochondria are getting dysfunctional, they are likely to have more release of the pro-inflammatory cytokines, and these changes within the Cooper cells, they are more likely to release pro-inflammatory cytokine in the form of TNF, alpha, and IL-6. In fact, Cooper cells are the only cells in which there is no upregulation of the UCP, uncoupling protein. And because it cannot happen there, so there is excessive release of the pro-inflammatory cytokines from the mitochondria, resulting in inflammation. In fact, ROS also have other disgruntling changes within the liver, and these ROS come from, they do come from dysfunctional mitochondria because the occurrence of the endoplasmic reticulum stress, and because microsomal and the paroxysmal oxidation is not used to tackle so much of the reactive oxygen species. All these leads to stimulation of the endoplasmic reticulum stress as well as the activation of the pro-inflammatory cytokines. Iron is another thing which has been implicated for causing injury within the liver. In fact, iron stores within the Cooper cells are stored, which tend to stimulate the transformation of the hepatic stellate cells into the myofibroblast, leading to the development of the fibrosis. In fact, there are various mechanisms which have been proposed how excessive dietary iron can produce problems at multiple levels. And it has been shown that in patients who have thalassemia trait, because of the ineffective hematopoiesis and excessive deposition of the fat in the liver, these individuals are 4 times more likely to develop advanced hepatic cell necrosis and inflammation. In fact, it has been shown that iron also stimulates NF-kappa beta to produce more pro-inflammatory cytokines. So whatever has happened, let us believe it has happened. So the body still tends to tries to adopt it by doing something called autophagy, which means that by using lysosomal pathway, which acts as a housekeeper to take care of the damaged organs and to replenish the nutrition. In fact, it is a part and parcel of day-to-day functioning of the hepatocytes. In fact, 1 to 5% of all proteins are recycled within the liver by this process of autophagy. But what happens in autophagy is this is the diseased organelle, like say a diseased mitochondria, diseased microsome, or diseased peroxisome, or diseased or fatigued ER that combines with the lysosome to produce autophagy. It has been shown that there is an ineffective autophagy in patients with MSLD. So there is an impaired lipolysis, and that leads to increased deposition of the fat in the liver, and that per se restrains autophagy. So if there are mechanisms for increasing autophagy, maybe part of the ongoing process may be checked. In fact, it has been shown that the down-regulation of autophagy is important as a cause of the stimulation of inflammation within the liver. In the normal course of the events, autophagy is a beneficial thing because it decreases the stress which is produced with the oxidation. It protects the injury from the TNF. It protects the ER stress which is occurring because of the reactive oxygen species. It gives you back the nutrients which are depleted because of the death of the organelles, and it also decreases the insulin, decreases the steatosis, thereby the insulin sensitivity. So once you have a altered autophagy, which is so important in patients with NAFLD, which has never been addressed to, certainly you are more likely to have disease. Finally, what about the genetic factors? All of us know that lipids are stored onto the endoplasmic reticulum by the combination of all these components. So incoming tag uses all these components to produce this substance called VLDL, which needs to be excreted. So a defect at any level, either at methionine, choline, or betaine, can lead to suppression of this chain of formation of VLDL and excretion into the liver. And this is where drugs like S-adenosylmethionine and vitamin E can be used, as they tend to replace S-adenosylmethionine. Other genetic defects are also known which prevent the formation of the tag, and there are other genetic abnormalities which prevent the exit of the fat from the liver. And in fact, there are deficiencies of the ApoB by genetic mechanisms which can lead to defective lipid production. So defective lipid production as well as defective extrusion from the liver can result in excessive accumulation of the fat. And once that fat gets accumulated, there is an ongoing lipolysis which will come. So these are the genetic defects like DTAG2 deficiency or ApoB100 deficiency, which are likely to produce more fatty liver disease. There is also some role of dysbiosis of the gut and the microbiota. Gut microbiome has been shown to result in increased intestinal permeability. There is increased absorption of the monosaccharides, and it has been shown by multiple mechanisms. Dysbiosis of the gut is known to cause increased absorption, increased extraction of the energy. In fact, there are 1.5 kg of microorganisms which have been implicated in pathogenesis of NAFLD. And the composition of the bacteria is altered in patients with NAFLD. There are more of, in fact, there is a reduced production of the bacteroids and more of firmicutes. And this observation can come from the fact that we know that microbiota tend to increase the efficiency of the energy extraction. They lead to the gut inflammation and the stimulation of the gut flow. They decrease secretion of the lipoprotein lipase inhibitor, and they also tend to modify the conjugated bile acids. All of these are so important in causation of the inflammation within the liver. In fact, it has been shown that if these not only act on the GI tract, they have wide systemic effect, and that is the reason the microbiota has not only been implicated in NAFLD, but it is also a source of the problem for so many other diseases. In spite of whatever I have said, there is still a defensive mechanism called natural killer cells, which will recognize that abnormal glycolipids within the hepatocytes and try to give them anti-inflammatory cytokines. So in simple steatosis, you have reduced expression of CD1, and hence NKT cells are depleted. Whereas with passage of time, NKT cells are important for causing wound healing. So they are recruited more and more. And once they are recruited, they'll cause more inflammation and more fibrosis. So what happens in patient ultimately with the ASLD is there is imbalance between the stressors and the adaptive mechanism. Adaptive mechanisms can be in the form of extruding the VLDL, trying to take care of the oxidants, and as well as trying to adapt the cells. Once they are all exhausted, that is the time then that leads to development of the cell death, which is so important for causation of the inflammation, which triggers the development of the fatty liver disease. In fact, there are three types of death which occur in patient with in a normal course of the event. Apoptosis is something which is useful because it is a programmed cell death. Necrosis is something which is caused with the bacteria-active inflammation. What happens in MASH, NFLD or MASH is something called necroptosis. That means you have apoptosis in which there is not enough way of doing a autophagy of this apoptotic body, resulting in occurrence of inflammation. And that is where drugs like metformin and other drugs like amikarsin are supposed to be useful. So the sterile inflammation is a part and parcel of ongoing hepatic necrosis, which is occurred because autophagy is not occurring, and that leads to stimulation of the Cooper cells. And apoptosis per se is likely to cause a release of pro-inflammatory cytokines from number of agents which I have mentioned, leading to development of the fibrogenesis in patient with NASH. So what are those inflammatory markers which convert the fatty liver into a inflammatory state? You have a combination of the PAMPs and DAMPs, which activate cellular mechanisms. You have lipids, which you have the lipid which are having altered shape, they activate the immune system, and there is a lot of altered microbiome which is causing inflammation. So the two types of cellular as well as the cytokine parameters, they are tending to cause inflammation, and this inflammation occurs basically in the form of occurrence of a substance called inflammasome, which promotes inflammation, and this inflammation suppresses anti-inflammatory substances and causes more inflammatory substances. So in patient with the diseased liver, you have LPS, which stimulates TLR4, and the LPS, which comes from the gut, leads to stimulation of the NF-kappa B, which is a pro-inflammatory cytokine, which it's the gene which leads to production of the pro-inflammatory cytokines, leading to stimulation of the hepatic stem cells and hepatic stellate cells. And once you have stimulation of the hepatic stellate cells, you have an ongoing persistent inflammation. And once this hepatic stellate cell has been activated, there is a downstream signaling leading to development of the fat, fibrosis, etc. So there may be a multiple hit theory. So once, as I've said, because of the insulin resistance and the diseased fatty tissue, you have a first hit, which is leading to the development of the fatty liver disease. So far as you have only tags and the blind fatty liver disease, nothing happens. But as new upcoming multiple hits are coming in the form of either oxidative stress or lack of apoptosis or lack of autophagy or failure of regeneration or stimulation of the fibrogenic agents. So there is a progressive deterioration of the phenotype from simple fatty liver disease to fibrosis to cirrhosis and hepatocellular carcinoma. And that is precisely the reason, because so many mechanisms are involved in development of the fatty liver disease. That is the reason that 75% of the patients have fatty liver disease. Only 1 to 2% of the adults will have cirrhosis of the liver disease, because there are so many other mechanisms which could be protected at various levels. So a defective repair and defective regeneration leads to deposition of the collagen and fibronectin, which ultimately leads to fibrosis. And stimulation of and activation of various pathways like hedgehog as well as fibronectin hedgehog pathway leads to stimulation of persistent fibrosis and inflammation. And this signaling of hedgehog affects almost all cells within the hepatocytes, leading to unchecked production of inflammation and ongoing hepatocellular necrosis. In fact, there are theories which tell us that it is possible that fatty liver disease can go into NASH, and it may only be one-way process, or it may not be a two-way process. And these may just be two distinct pathologies. Some patients are destined to have only fatty liver disease. Not every fatty liver disease to go into a NASH. So it is possible that so far as the fatty liver disease patients are able to adapt to the stress which is given by the insulin resistance, they'll never develop NASH. NASH will develop only if there is a ongoing inflammation which leads to oxidative stress and the number of other stress which leads to release of the pro-inflammatory cytokines at different level. Once you have pro-inflammatory cytokines, you will develop NASH. And once NASH occurs because of the stimulation of the hepatic stellate cells, you have fibrosis. So that is the reason all these new drugs which have been shown or which have been in vogue for treatment of NASH these days, they tend to improve inflammation in the liver. To sum up, ladies and gentlemen, in a normal patient with liver, to have fatty liver deposition, you need to have activation of the drivers of the fat, which could be in the form of diabetes, intake of the high caloric diet, high fat diet, onset of the insulin resistance, in the presence of the genetic abnormality which predisposes to this. Once fatty liver disease has occurred, you need to have second set of drivers of inflammation in the form of Cooper cells, hepatocytes, adipocytes, or free fatty acid metabolite, which lead to production of the reactive oxygen species, which leads to disruption of the mitochondria, endoplasmic reticulum, cytochrome, and the peroxisome, which lead to production of inflammatory and cellular cytokines, which leads to development of the fibrosis and cirrhosis of the liver. That is the reason, if you look at the various drugs which are being used for treatment of NASH, they have been supposed to be acting at almost different level, but unfortunately, this still boils down to theory. And only one drug which has been approved by US FDA is the drug called resmetirom, which only increases the fatty oxidation. These are all the drugs which are in the pipeline. I have shown you the various mechanisms where these drugs are acting, but unfortunately, most of these drugs are still in the phase 2B or phase 3 trials. What we have to concentrate is, depending on what state does the patient come to you. Does the patient come to you at a stage of fibrosis, of simple fatty liver disease, NASH, or cirrhosis? You may have to choose a drug which decreases fat deposition, drug which acts as an anti-inflammatory agent, and drug which will undo the fibrosis. To sum up, ladies and gentlemen, the pathophysiology of non-alcoholic fatty liver disease and NASH is complex, as numerous intermediaries are involved. Each year brings new and exciting development as pieces and pathophysiological puzzle are put together in a new pieces are elucidated. As the prevalence of the disease continues to increase at an alarming rate, I think we need to concentrate more on understanding the clinical pathways of pathogenesis, which are so essential for development of the novel drugs, which are important targets for effective therapy of